I came to medical school out of Tuskegee Institute in 1975. Finished medical school actually in 1980 from the University of South Alabama. Um, the only African American in my graduating class. Um, the first I stayed here and in residency in internal medicine, first African American to train here in internal medicine in any residency training program. And from there, I was a chief medical resident, and I stayed and did a pulmonary fellowship here. Um, and following, and was the first of all of those. And finally left, went to the University of Colorado, and did a 2-year research fellowship in the cardiovascular pulmonary research labs, looking at uh, and studying pulmonary vascular reactivity and studying acute lung injury uh, in the in a rat lung model that I developed, and that was 86 through 88 in Colorado. Came back in 1988, first African American on faculty here, and I've been here since on the faculty here at the university. It was challenging, as it was for everybody doing the same things, but it was a bit more challenging when you looked around and you never saw anybody who looked like you. And it wasn't so much that people were less than friendly or whatever. It was just a matter of, you know, we don't like to talk about it, but we have cultural differences. We have life experiences that reflect a reflection of the environments in which we grew up in. Oftentimes it was then very, very lonely as well. Uh, in medical school, uh, I had one very, very good friend throughout, a gentleman by the name of John Gotch, who's ultimately went on to be a professor at Johns Hopkins in the Wilmer Eye Institute. And that relationship is what, uh, through medical school, made things uh, uh, tolerable at the time. The environment was less than sensitive, um, and you learn to maneuver in that type of an environment uh, by keeping your nose to the grindstone, doing the work. Uh, but it was not a lot of fun, needless to say. Not that it was fun for anybody, but there were additional factors that made it a bit more stressful than it would have for most of my colleagues. There's been a significant change in terms of in the classroom. There's more diversity in the classroom than ever in the history of the College of Medicine. There's more diversity on the clinical faculty side than it's ever been in the history of the College of Medicine. There still is essentially no diversity in the basic science departments, and there has never been anybody other than myself. I had have a dual appointment on the clinical and basic science side, but other than me, there's never been another African American that's ever been in the history of this institution on the basic science side of the College of Medicine. So clinically, from a student standpoint, we've come a long, long ways. From a residence and training, we've come a long, long ways. From the clinical faculty, we've come a long way, still have a long ways to go. And we've not moved at all in terms of basic science faculty when it comes to people of color. I reflect back again when I came through as the only in various phases of my education. It's the same way in terms of the impact on communities. When not having physicians that mirror the community in which healthcare is being delivered, it has an impact in terms of people's lack of comfort in terms of just communicating honestly and accurately about their overall clinical conditions, or the passion in which one might have, not everyone, but might have or might not have in terms of serving the different communities. And I can remember as a young intern uh, in my internal medicine clinic, the first time I had a group of elderly black patients, for the first time had seen a black physician, and they would come and they would want to sit and just talk for prolonged periods of time, which wasn't feasible in terms of looking at the turnover in your clinics. But for the first time, they felt comfortable asking questions about their own health care. They were accustomed to being told and felt that they didn't have they didn't feel empowered to ask about their own health care. That's where things have been. As we create a more diverse workforce, uh, communication barriers are breaking down. As we create a more diverse classroom where cultures are actually coming together and people are actually talking, I think it breaks down barriers for the healthcare providers that are from different racial and ethnic backgrounds when they address others from different racial and ethnic backgrounds. And so by diversifying our classrooms, diversifying our healthcare delivery system, the, the system is better prepared to care for a diverse population. And that works from both sides of the on both sides of the street. You know, I'm better prepared to take care of people who don't look like me because I have colleagues uh, coming from different cultures, and we sit down and we talk, and it just kind of happens really in a more passive way, just by diversifying the areas at various levels of training and practice. In my neighborhood, we have this community uh, uh, email system where they'll ask, you know, what's the best place to get your care? And I'll say the university hospital healthcare system is by far the best healthcare delivery system in this part of the state of Alabama, without question. Um, um, and I say that because I've been in it for so long, but I also know the people and I've seen how it has evolved and it's continuing to evolve to meet the needs of the communities in which we serve. So, uh, um, you know, in my opinion, uh, healthcare, standards of healthcare start at university hospital systems. They don't start in private practice. And it is the responsibility of a university healthcare system to be on the cutting edge of every aspect of healthcare delivery. So we have to be the best as a university. And we have to also, however, be able to effectively communicate with our partners in medicine across the community and our private practice colleagues and whatever. So, and that's one of the things that I think too has improved over time, and that is um, university physicians communicating more effectively with individuals in private practice. And some of that is probably related to the physicians who come out of our College of Medicine that stay in our communities to practice. So most of our problems would be much smaller than what they are if we had more effective modes of communication between the different groups. Everybody's going to look out for themselves, let's be real. But being able to communicate and to be open to talk about difficult subjects is what's going to get us past this point and help us to all grow. I celebrate Black history. I don't just celebrate the month of February. For me, it's all based on what, you know, history implies things that have already been done, you know, things that have been done in the past. But it's dynamic and a continuum. for me, Black History Month is a time to, of course, to celebrate. It's where others outside of the Black communities tune in to this whole notion of Black history. But the other 11 months, it's like it doesn't exist. But Black history is a continuum. It impacts our daily lives every day, every month. Um, uh, how do you, and I have to ask myself, how is it that you maximize the impact of a race? Um, it's all based on what you do. The problem is that one who writes the history, because everybody's bias comes in terms of when that history is written, uh, whether it is incorporated in our kids' day-to-day lives in their history classes. For the most part, it's not. Um, so Black history needs to be a part of American history, and the media, I think, in large part, sometimes influences how that history is portrayed or not portrayed. Sometimes I dread turning on the daily news because what's going to be put out there is going to be some negative because that's what gets people's attention. It's not going to emphasize that Black kid that's a scholar. It's not going to emphasize that Black kid that's a dancer. Uh, uh, it might emphasize, that kid that's the scholar athlete. Um, the key is um, you have to have, we need to be in sync. We need to focus more on good news. Uh, on the good news of communities, to build communities. Um, one of the things, for example, that we've recently started here at the university is we become an affiliate chapter of Black Men and White Coats. When you look at the numbers in terms of physicians that are Black, it makes up about 5% of the total population of physicians in the United States that are Black African American. And of those, 2% are Black men. And so when it comes to Black history, I hope when I've retired from this that a part of the history that I will have left in terms of Black history at the University of South Alabama College of Medicine, beyond just being the first of most things. I wasn't the first medical student, but after that I was the first everything here. I like for them to talk about Black Men and White Coats and how it's impacted in terms the enrollment of Blacks in general. And I say that very, very proudly because there's a need for that. And Black men in particular. As being a Black man, and hopefully I've done the university and my community proud in terms of my career here at the university. So I like for those things we talked about. I started the Office of Diversity and Inclusion here at the University of South Alabama College of Medicine. I like for that to be a part when the university writes its next history book about the College of Medicine, that the things that the first one didn't include anything about the Black history. It didn't mention John Wagner, the first African American male, or Pat Sanders, the first African American female, or anything. It was the University of South Alabama College of Medicine, but the Black history component was not incorporated in that document. It should have been, and I hope the next time that type of a document is put in place, that there's some accurate recording of the history of the University of South Alabama. How we move from a period of a consent decree and mandates in terms of what we have to do to improve the diversity within the healthcare field, and to show how far we've come, because we have come a long, long ways, but we can't stop. You know, if you look from the top down, it darkens as you get towards the bottom. We need to darken it a little bit toward the top as well, because what I have learned is this, and that is having a place around the table where decisions are being made rather than just being the recipient of decisions made makes a big difference. The outcome, the impact of change when you've got a hybrid input into the development of various concepts and ideals and policies and whatever that creates change in an environment is a reflection of the people making the decisions. And if you don't have people from the top down, the decisions are not going to reflect those that don't have a voice in and around that table. So diversity matters.